And our speaker tonight is Dr. Chris Cirucci. Dr. Cirucci received her MD from Jefferson Medical College and completed a residency in OB/GYN at the Medical College of Virginia, and she's worked in the field for 20 years. She's one of the authors of A Scientific and Medical Evaluation of Transgenderism, which was a white paper that RTB commissioned recently. And as I mentioned, she also has written a chapter in RTB's most recent book, Revealing God in Science. So please join me in welcoming Chris Cirucci.
Well, thanks everyone for coming, and thanks Kirby for that introduction. Um, yeah, as Kirby said, I'm a board certified OB/GYN physician and have done some research on this topic on gender affirming care and those issues with reasons to believe. So today I'm going to be talking about gender affirming care, examining the evidence. So I'm really going to be looking at this from a scientific medical perspective, looking into the literature and what does it say? Because we always like to know the truth. So, just as a background, the objectives tonight are to review the terminology and background regarding gender dysphoria, discuss the changes that have occurred recently in terminology, epidemiology, and the standard of care. I will explain the 4 steps of gender transition, evaluate the scientific evidence for or against gender affirming care, and also discuss the relationship between gender dysphoria and mental health, which is a big topic. So I, I think I put this slide up because I think if you're older than 30, you think in the last 5 or 10 years, like what happened? Like everything just seemed to change. And I'm going to talk about some of that. There's a lot of philosophy behind what happened, and but as a physician, I'm going to talk about the medical aspect of this. So just first of all, some general terminology and background. So the issue of gender dysphoria, transgenderism, etc., was not even in well, this book here is the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. So it is basically the psychiatric Bible. Every mental illness is in here with its criteria. So the gender issues weren't even in here till 1980, and the term used was transsexualism. And then in 1994, with the next version, they changed the terminology to gender identity disorder. Then in 2013, the DSM changed their terminology to gender dysphoria, which is the current terminology. They wanted to take away disorder because they now considered it a normal variant, but they're still including it in a book of mental disorders, I think, because then you can get insurance coverage. Then there was a revision to the DSM that came out in 2022, and they changed some terminology. Very interesting to look at subtle, not so subtle changes. So instead of someone's desired gender, they refer to it as their experienced gender. Instead of cross-sex treatment, they called it gender affirming treatment. And instead of natal male or female, they refer to it as assigned male or female at birth. Now, as an obstetrician, I've delivered thousands of babies. I have never assigned sex at birth. I announce the sex. I don't assign it. So, but that's the terminology now. Don't worry, I'm not going to go over this whole slide, but in the DSM, in this psychiatric Bible, they will have criteria for different disorders. So in adults and adolescents, the criteria is a marked incongruence between one's quote unquote assigned gender and their expressed gender of 6 months. And it has to be associated with clinically significant distress. And then in this list of 6, there has to be at least 2 of the following. So there is criteria for this diagnosis, but it is more a person. There's no test or lab test or to diagnose this disorder. So the terminology has changed, but also epidemiology has changed. Epidemiology is think of demographics and incidence and who gets this, who does this apply to. So historically, until very recently, gender dysphoria was extremely rare, about less than 5 per 100,000 people. And it also occurred in two very distinct populations. One was in young boys, very young boys who, at the age of 3 or 4, exhibited gender atypical behavior. And this was called early onset gender dysphoria. And actually, these young boys, if not given medical intervention, would with time typically become comfortable with their birth sex. And then the second group was the late onset gender dysphoria. This was again males, adult men who often live in as years as are heterosexual, married with children, would express desire to be a woman. So in this category, you can think of Caitlin Bruce Gender, Rachel Richard Levine. So again, historically very rare and typically either in very, very young male children or adult men. Well, now, as you were very aware of, this has all changed. In fact, um, one source says that 3.3% of adolescents in the United States now identify as transgender, and 2.2% question whether they may be. So the 3.3%, this is over 700 times the historical incidence. But it's also in a different population. Now it's instead of being rare, it's common. Instead of being very young boys or adult men, it's adolescents, and they're mostly female. This graph, just to get the picture, this is a graph of the people who were referred to the Tavistock Clinic, a gender clinic in England, which is now closed. But you can see on the left-hand side, 2009, that number was small. And just over the next 10 years, really rapidly increased. And the yellow there are the girls. And so, and the blue is a boy. So not only do we have a much increase, it's a different age group and it's females rather than males. Well, this is what we now call rapid onset gender dysphoria. And I will tell you that this terminology, ROGD, is disputed. I guess the people who are pro-transgender do not like this terminology. But this was first coined by Dr. Lisa Littman, who published a peer-reviewed study where she did a survey of parents who reported that their adolescents all of a sudden, exhibited gender dysphoria. So this is like the kid that comes home out of the blue, everything's fine, and then all of a sudden they say, I want to be a boy. And Dr. Littman found some very interesting things in this group of people, in this group of kids. So almost all of them were female, 83%. 81% had no history of gender dysphoria. These were not kids that had struggled through their life. These were kids who came home out of the blue. About 2/3 of them had a mental health issue, pre-existing, or a neurodisability such as autism. About half had a prior traumatic event. About 2/3 had had an increase in social media use just prior to their announcement. Also, about 70% had a peer group with another transgender person. And most parents felt that their children used language they found online. So this is rapid onset gender dysphoria. This is what we're mostly seeing today, a lot of what we're seeing today. And if you want to read more about this, I would highly recommend this book by Abigail Schreier called Irreversible Damage. It's not a Christian book, but it's very well written and very well describes the phenomenon happening today. So in addition to the terminology changing and the demographics changing, the standard of medical care has changed. So historically, and in this talk, I should have said this in the beginning, I'm going to be, unless I say otherwise, I'll be talking about adolescents, the young people, the people we're seeing today. So historically, in minors, the standard of care would be what's called watchful waiting, a thorough psychiatric evaluation, support, time. But now, what's considered the standard of care is called gender affirming care. This means that the person is affirmed in their desired gender with minimal evaluation. The thought is that patients know what they need and children know what they need. So this is not just out there in a few gender clinics, but gender affirming care, this model of care is used by most clinics, endorsed by major medical organizations. And it must be pointed out the diagnosis is made by the patient, not the physician. It's a self-report, meaning I feel like a boy. I'm a boy. Okay, then you are a boy. This is gender affirming. So again, so many of these kids have underlying issues, trauma, abuse, family issues, mental health issues that need to be addressed. But instead of exploring the underlying issues in gender affirming care, the healthcare professional is obligated to affirm that person's chosen identity. And then they can quickly provide puberty blockers, cross-sex hormones, and on with to a young person with little evaluation. So again, minimal evaluation. The diagnosis is made by the patient, not the physician. It depends on self-report. There's no test to diagnosis. So it's just a self-declaration. And transition takes precedence over exploring the underlying issues. This, Do No Harm, this is a documentary in the Daily Caller. It's not to be confused. There is an organization called Do No Harm, which is fine, but this is I think you could just pull this up on YouTube, which I'd encourage you to do. So this young girl, um, it's kind of like this young reporter. She's probably 25, but she looks like she's 16. And she calls Planned Parenthood and said, "Well, I want hormones." Um, and they say, "Okay, come in." And she has all this on tape and on video, and she just says, I want testosterone. And she goes in the whole visit, which is like 15 minutes or less or whatever, is on tape, almost no evaluation, and she walks out with a prescription for testosterone. So that's gender affirming care, affirming the person in their gender. And then what happens is there's a process of gender transition, which I'd like to explain. So if someone desires to look and appear like the other gender, the process they will go through, it's basically 4 steps. There's social transition, then puberty blockers, then cross-sex hormones, then gender affirming surgery. And I'm going to go through each one of these, and then I'll discuss the science or lack of it. So step 1 is social transition. What this means is the person wears the clothing, the name, the pronouns, the hairstyle. Now, girls may do chest binding. This isn't just wearing a sports bra. This is really tight binding the breast to make their chest appear flatter. They packing to provide a bulge at the groin. Boys may also use stuffing to make, to give themselves look like they have a chest. And then this very awkward and I'm sure painful procedure called tucking to hide the penis and scrotum. So sometimes social transition is thought to be reversible. So it's logistically reversible. Certainly, if someone goes by a name, they can change that back. But this would be very logistically difficult. I mean, it's logistically possible, but difficult to do so. So imagine a young girl who everybody at school knows her as Jack, and they don't know she's really Mary. And then you imagine how hard that would be to revert back. In this book, Lost in Transnation by Miriam Grossman, highly recommend this book. She talks about chest binding as a gateway drug. And I think the social transition is a gateway drug. It can send a person on the path. And people may think that social transition is without harm, but it's not without consequences. As I said, it's difficult to reverse. And there are also concerns medically. We don't really have a lot of peer-reviewed studies. There's no peer-reviewed studies about chest binding in girls, but most girls report adverse effects, shortness of breath, back pain. And then tucking in boys, again, no definitive studies, but we have reason to believe this would affect sperm formation and fertility. So now I want to talk about the next step, which is puberty blockers. So if a young person has not yet gone through puberty or has not completed puberty, they may go on puberty blockers. And what a puberty blocker does, it halts the normal process of puberty. So it suppresses the hormone called gonadotropin releasing hormone that causes the release of estrogen and testosterone. So it's estrogen in a girl that brings about the secondary sexual characteristics and testosterone in a boy. And this drug will stop that. The drug in the US is called leuprolide acetate. This drug is FDA approved only for endometriosis in women, fibroids in women, prostate cancer in men, and precocious puberty in children, not to be confused. So when it's given in precocious puberty, we're talking about a child at 5 years old who starts going through puberty. Leuprolide is given until they come to the normal time and are allowed to go through normal puberty. In a transgender identifying kid, leuprolide is given to completely stop their normal process. And I've used this a lot as a gynecologist for as endometriosis and fibroids, and women are miserable. There's so many hot flashes, and we only use it for 6 months because of its side effects. But what parents are told about puberty blockers is, well, it will just buy time. They're reversible. But the truth is that although, again, perhaps you could stop the drug, there are some permanent effects, but 96 to 98% of those who go on puberty blockers go on to the next step, cross-sex hormones. And there are significant adverse effects from puberty blockers, decreased bone mineral density. And this is at a time when the young person is having the most bone growth. This is when they're developing bone and it affects bone mineral density. Again, that's why in women we only give it for 6 months. Loss of sexual function as an adult, sterility, neurologic effects that are not completely understood. Is definitely harm from puberty blockers. So again, they're not completely reversible because they have some significant permanent effects, and they don't buy time because almost all, and this has been shown through multiple studies, go on to take the next step, which is cross-sex hormones. So cross-sex hormones means that, so if we take a young girl who says she wants to be a boy, so she's been given leuprolide, puberty blocker, to stop her estrogen, and now she's going to take the opposite sex hormone or testosterone. So these are given to induce the secondary sex characteristics of the opposite sex. A girl who desires to be a boy will take testosterone. She'll develop facial and body hair, a deepened voice, fat redistribution, increased sex drive, etc. A boy who desires to be a girl will be given estrogen, increased body fat. He will have decreased lean body mass, decreased libido, decreased sperm production, erectile dysfunction, decreased facial and body hair, breast tissue growth, etc. And there are significant side effects to these. Both of these increase risk of heart disease and stroke. Testosterone, increased risk of high blood pressure, liver dysfunction, increased red blood cell concentration, adverse effects on lipids. Estrogen has significant adverse effects, heart disease, stroke, breast cancer, clots. Estrogen is known to be associated with causing clots, benign pituitary tumors, gallstones, high triglycerides. So this is a quote from the Endocrine Society from their clinical practice guidelines. And I will tell you, the Endocrine Society supports the use of cross-sex hormones. They are totally on board with this there, and they say future research is needed to ascertain the potential harm of hormonal therapies. So here they are giving and supporting the administration of these hormones to children, yet admitting that future research is needed to ascertain the potential harm. And then some, but not all, will go on to have surgery, gender affirming surgery. What used to be called gender reassignment surgery. Um, there's people that disagree about the names, but in any case, the most common of these surgeries would be a mastectomy. So a girl who desires to be a boy will have her breast removed. And if she may also have what's called bottom surgery. So this is removing her female organs, the uterus and the ovaries, closing off her vagina, and then creation of a penis-like structure, a procedure called a phalloplasty or metoidoplasty, and then prosthetic testicles. Um, a man or male or boy who desires to appear female may have breast construction with implants, facial and vocal surgery, and genital surgery. So this is removing the penis and testicles, and then a vaginoplasty, creating a vagina-like structure and external female genitalia. As you can imagine, the genital surgery is extremely complicated, obviously permanently disfiguring, and there are significant detrimental effects on sexual and genitourinary functioning. I'm a surgeon. When we do surgery, we look at the risks. Every surgery has risks, but the percent of complications from these surgeries is quite high. So, for example, removal of breasts, that one of the biggest things with removal of breasts, a young girl, you hear these young girls who have regretted what they've done. They've had their breasts removed because they wanted to look like a boy, and now they will never be able to breastfeed. They've had their uterus and ovaries out, and they're permanently sterile. They have decreased estrogen production if they've had their ovaries out. So they've been put right into menopause, and they will never be able to bear a child. If they've had a phalloplasty, so this is creation of a penis-like structure. This is a very complicated surgery. Again, lots of complications, as high as 76%. Complications such as fistula and stricture. These are very serious complications. A metoidoplasty is a less involved procedure than a phalloplasty, but it also has significant complication rates, and about 1 out of 10 go on to have the more complicated procedure anyway. So again, a male on the other side, a male who desires to appear female, may have breast augmentation, vocal cord surgery, facial feminization surgery, genital surgery, as I mentioned, removal of the penis and testicles, and then construction of a vagina-like structure. I'm going to get a little graphic here so you can turn the sound off if you don't want to hear it, but I think it's important to know how what's being done here. So the most common way this is done is penile inversion vaginoplasty. Yes, they're taking the tissue from the penis and inverting it to make a vagina-like structure. High complication rate. Now, interestingly, if the person has taken puberty blockers, there's not enough tissue, and so they use the intestine. And then this person always has a ongoing malodorous discharge. These are not simple surgeries. These are permanent surgeries. And when you do any surgery on someone, you need to look at the risks and benefits. What are we fixing? What are we helping? And what's the benefit of this weighed against the risk? So I'm going to move on. That's kind of the summary of transition, but I want to talk a little bit about first the World Professional Association for Transgender Health, WPATH. Now, the WPATH presents itself as a medical organization. It was started in 1978 under a different name, and they produced their first quote unquote standard of care in 1979. If you look at who started it, it's a combination of medical professionals and transgender activists. they changed their name then in 2007 to WPATH. And so they have put out these standards of care. This is version 8, which is 300 pages, gives all what they call, I hate to call it standards of care because it's appalling. I've studied this document. Um, and we'll go into that in a little bit more detail. But this is the guide that the gender people will use, like to give their care. So this is the most recent version, version 8. And just to summarize this for adolescents, their criteria, there is no lower age limit for somebody to transition. They do what's called stage, not age. So a young person can receive puberty blockers and cross-sex hormones right at the start of puberty. Just as they start to enter puberty, the medically term is Tanner stage 2, they can receive puberty blockers and then cross-sex hormones. And then they can go on to have surgery in 12 months or less. 12 months is preferred. No referral letters from a psychiatrist is required. Parental consent is not required. It's desired but not required. And the medical and mental health issues don't have to be taken care of. They just have to be addressed so that this care can be given. So, girls may go through puberty at 8 to 9 years old. So we're talking about very young kids getting transitioned. On the left side of this slide is a standard of care in 2012, standard of care 7. On the right side is the current one that I just discussed, standard of care 8. I want to show you what's changed. So 10 years ago or 13 years ago, a person couldn't get hormones or surgery until they were at the age of majority, so 18 years old in the US. They had to have a referral letter. In fact, for general surgery, they had to have 2 referral letters. If they were a minor, they had to have parental consent. And their medical and mental health issues had to be well controlled. Now, in 10 years later, there's no lower age limit. There's no referral letters. Parental consent's not required. And the medical and mental health issues, they changed the terminology from well controlled to addressed. Now, you may have heard of something that came out about a year ago, which called the WPATH files, which was basically somebody was able to get some of the emails and some back information on what was going on at WPATH. Although, if you read their documents, it's clear the bad science. But the WPATH files, the whistleblower here concluded that the WPATH guidelines are not scientific. They're not advocating for ethical medical care. They recommend arbitrary and unethical medical procedures. They don't meet the standards of evidence-based medicine and violate the requirement to obtain informed consent. It's kind of a quick overview. We could go over all these in so much more detail, but so I'm going to answer the question by looking at a little bit of the data. Is gender affirming care supported by the evidence? Because the people that promote this say it's necessary. This person has gender dysphoria. And so this is the answer. And kids are told, well, you're in distress. You think you're a boy or think you're a girl. Well, you need to transition. And they often think that will help their situation. So your organization is called Let the Evidence Speak. I think we all want to know evidence. So I'm going to look at the medical evidence. So where did this all start? It did come out of the blue, it seems, in the not too a distant past. But where this started was a couple of studies referred to as the Dutch protocol. So the first study was performed in Holland by De Vries in 2011. So what they did in this study, in fact, they kind of came up with this idea, hey, we have these kids with gender dysphoria. Why not just stop their puberty, give them puberty blockers? So they took 70 young people, gave them with gender dysphoria. They gave them puberty blockers. And they evaluated the psychological effects of the puberty block over 2 years. They found that these kids had improvement in behavior, in emotional problems, in depression, and general functioning. They had no change in anger, anxiety, gender dysphoria, or body dysmorphia. Now, some issues with this DeVries study. They had no control group. So we have 70 kids giving them a medicine. We don't have a group that received nothing. So we have no placebo group. Also, these kids all received psychotherapy. So the areas where they did have benefit, which one helped? Was it the psychotherapy or the puberty blockers? Another thing to be aware of about this study is this is a different population than the kids we see today. The kids in the Dutch protocol, these 70 kids, had gender dysphoria in childhood, not adolescent onset. They lived in a supportive environment. They had to have no comorbid psych disorder. These are not always the case with kids today. But let's move on. DeVries then did a second study where they followed these kids, these people out farther. So what they did, and this was published in 2014, study 2 of the Dutch protocol. They assessed these people before puberty blockers, before cross-sex hormones, and then 1 or more years after surgery. They stated their conclusion was that in young adulthood, their gender dysphoria was alleviated and psychological functioning had steadily improved. However, if you look at this study, of the 70 kids, they only included 55. 15 were excluded, including one young person who died. One young person died of a infection shortly from a vaginoplasty procedure I talked about a little earlier. So we have over 20% that were excluded from the study. That's a problem. And as I said earlier, different population than today, no control group. Patients received both psychotherapy and puberty blockers. And we have 15 out of 70 who were excluded from the study, one of whom died. I don't know of anything in medicine where you have more than 1% of a young person having a procedure who dies and you would make that standard of care. So if the Dutch protocol, if these two studies were just the initial studies that then were further studies looked into it, and again, I'm not even speaking ethically of this. I'm just really speaking medically as a physician, as a scientist, like, you know, if there were further studies done from this, and this were just the initial study, but there haven't been any replication of this. These early studies form the foundation of youth gender transition today, and they have never been replicated. This is a statement from the American College of Pediatricians, not to be confused, the American Association of Pediatrics, or American Academy of Pediatrics. American College of Pediatricians is a conservative youth that is on the forefront of the fight against gender-affirming care. So they said there is not a single long-term study to demonstrate the safety or efficacy of puberty blockers, cross-sex hormones, and surgeries for transgender-believing youth. Now, I realize I've just talked a little bit. I could go through, you know, these Dutch studies form the foundation, and they've never been replicated. Obviously, there's hundreds and thousands of studies out there, and we don't have time to go through them. But if you look at all the studies, most of them are low quality, very few long-term studies. There are no randomized controlled trials, which is the standard of, you know, the gold standard. And we have many experts who have now come and spoken against these treatments. We know that many European countries have changed course. In fact, this, just as an example, this was 2 years, I don't know where the time flies. This was kind of where the things started to change in Europe. This was about 2 years ago in the Wall Street Journal, where 21 researchers or clinicians, people who worked in gender transition in it with these kids from 9 countries, none from the US, um, basically made a statement and said youth gender transition is being pushed without evidence, and psychotherapy should be the first line treatment, not gender affirming care. Another statement from an article by Laidlaw and others about saying there are no randomized controlled trials for the use of puberty blockers. The quality evidence is low. In fact, all of the evidence in the guidelines with regard to treating children and adolescents is low to very low because of the absence of proper studies. I'm going to go back. So that's a problem. What is being the treatment or intervention that is to be done on these kids with concerning problems and struggling with their gender and probably with mental health issues and otherwise, the this care that is being provided to them as a solution really doesn't have evidence behind it. It doesn't have evidence behind it. And finally, this came out a month ago from the US. Finally, the US, the Department of Health and Human Services, published um, there's a couple 100-page document on treatment for pediatric gender dysphoria. And I haven't read this whole thing yet, but they basically say the evidence for any benefit is uncertain, and the evidence for harm is less uncertain. And when medical interventions pose unnecessary, disproportionate risk of harm, healthcare providers should refuse to offer them, even when they are preferred, requested, or demanded by patients. Failure to do so increases the risk of iatrogenic harm, reduces medicine to consumerism, threatening the integrity of the profession, and undermining trust in medical authority. So, again, that's finally from the USHHS. Well, I'm going to go now to talk to, before we close, I want to talk about this question that often asked. Well, what about suicide? Because what parents are often told is, do you want a dead daughter or a live son? So they have a girl, or I'm sorry, a girl who wants to be a boy, and this is what they're told. Well, what a terrible thing to tell a parent. What's a parent to do? Transition their child, or they die? They're going to kill themselves? This is what kids tell their parents. So what we know about suicide is, first of all, suicide risk is already increased in transgender youth. The suicide is increased 13 times in transgender kids. It's also increased in other mental health disorders. Anorexia, 18 to 31 times. Depression, 20 times. Autism has 8 times the risk of suicide. And a lot of kids with gender dysphoria have these other mental health conditions. Now back to WPATH. WPATH's claims about mental health. They claim that psychiatric symptoms lessen with gender affirming care, and that gender affirming surgical procedures have been shown to improve mental health. Well, this is simply not true. We just don't. There are very few studies, very low. The studies that are there are low quality. One of the few long-term studies we have in the gender transition area is this one by Jane out of Sweden, and this is on adults. So in this study, 324 patients underwent sex reassignment surgery, and each of those were matched with 20 controls, 10 of their birth sex and 10 of the sex they were reassigned, whatever sex. And what was found? Those who transitioned, compared to controls, had 19 times the risk of suicide, 5 times suicide attempt, 3 times overall mortality, 3 times inpatient psychiatric care at 30 years. So this is a longitudinal study. It's not a randomized controlled trial, but this is over 30 years. So the best evidence we have actually suggests That gender transition increases suicide. In this study, by 19 times. The American College of Pediatricians published this booklet. I'm sure you can find on their website, or this paper, "The Myth About Suicide in Gender and Gender Dysphoric Children." And they state prevention of suicide for trans-identified youth is the same as for other youth. Talk therapy and FDA-approved psychiatric medications. They also state there is no long-term evidence that mental health concerns are decreased or alleviated after gender affirming therapy. So I would propose, I personally conclude that gender affirming care is unethical. It takes advantage of people in distress. These young people in particular with gender dysphoria, or some of them claim to be transgender. There's a variety of reasons, but they're in distress, and it takes advantage, providing them something that isn't going to help them and certainly harms them. And they deserve better.
That was pretty hard hitting, I think.
Yeah.
And I wouldn't know where to start with a question, but if anybody does have a question, please go for it.
Christina, this is Phyllis. I
Phyllis, go
have
ahead. Mhm.
I have a question, and actually I'm almost speechless. And I know you know that's not a problem for me, but I almost want to break down here because I guess my question is, how did they allow such procedure on a small child without parental permission or any detailed information when I, as an adult, I can't even get a referral, with a life-threatening illness? I have to have a referral. That's what ended me in ER twice because I couldn't get a referral. I'm just, I'm just that odd.
Well, I think Phyllis, you hit it exactly. I mean, it's appalling. It's like, what are you doing? And now I want to clarify something. The W path. So I said parental consent's not required. The way they state it is parental consent is preferred, or unless it's found to be disruptive or problematic. It's almost like there's this out to, like, if the parents disagree, they just can kick them out of the room. So yeah, it's appalling. And I think part of the answer to your question is that there is certainly an ideology behind this. Um, I'm not a philosopher, so I can't really go down that road. There's a lot there, but it's related to critical race theory. It's um, related to so much of this. I just read a book. I was in a book club um, on a book called The Queering of the American Child that talks about how the plan to get all of this, this didn't happen by accident. It's obviously very evil, um, but yeah. It's definitely planned, and there's an agenda there, and a whole philosophy behind it. So,
But,
which I really
but
not an expert to comment on that really outside the medical area. But yes, please.
but these are doctors. They're under oath critical care to help
Hmm.
people, not harm them. The
Yes.
data clearly shows that this is not very productive, and these are children.
Yeah,
How do you accept a child's? I
I'm with you.
guess,
I'm like,
I
what's
mean,
happening to my profession? But part of
this
it is
person
that
isn't
they're
old enough to make that kind of decision. I don't think they are fully aware of what it's going to happen to
no.
them.
No, and I didn't have time to get into that, but you're absolutely right. That these are being done without what's being called informed consent. There, and it's hard to cover all this in one short talk because there's so much there, but it's appalling. I mean, in doing this research, it's appalling. I'm like, and I, so yeah, we have to, I don't know, come against this and speak up the truth. I think that some physicians maybe, there's a problem now. There's a pressure to, if you don't go with the ideology, and this is the way with abortion too, physicians fear they will get fired from their jobs, and they have. Not that that's a reason to do the wrong thing, but I think there are some people that just hear the terminology or the narrative and believe it. And I think many of them that do this think it's helping, but it's appalling. You're absolutely right.
Where is the link, or I say the gap, where if as an adult I have to have all these referrals and as a child they don't? Where is the dividing line for physicians here? I mean, who makes these decisions? Adult has to have a referral, a child doesn't.
Well, I think what's happened is WPATH, this organization that's kind of a pseudo medical organization, and then there's all this ideology behind it, and they put out this quote unquote standard of care, and they hijacked that part of the system. You're asking really good questions that I don't have answers to because it's just so wrong. Um,
Is this driven largely by psychiatrists or general practice physicians or both?
oh, it's driven by the people, probably the people that do the transition. So it's everybody. It's pediatrics, endocrinology, surgery. I mean, it's a lot of different specialties. And um, yeah,
Is there a government organization that should be in charge of this or that is? What about the FDA or
well, that's
Centers
why
for?
finally the US came out with their statement. What's happened is, like I said, a lot of the European countries and other countries have they were the ones that were on the forefront of doing this intervention, and then they realized that, oh, our data is not good, and they turned course. The UK did that, many other countries, and then until this administration, it was just being pushed in this country too, till they finally, that was one of the mandates, was to do a dive into the you know transgender issues, and that report that I brought up was just published. Um, yeah, it's appalling. I mean, these are people's lives that are being damaged and being sold a bill of goods. And now I will say, Phyllis, some of what you're describing is an insurance company thing. So one insurance company may say you need a referral to go to to go to somebody in this specialty, and another insurance company may say you're not. So that could be an insurance company thing. And an insurance company could say, well, we're not going to cover this without a referral. But as far as what's in that standard of care, for what they're telling the medical profession who's giving these interventions. We have some more hands. I don't know, Kirby, do you want to?
I actually haven't. Oh yeah, I see that we have some, and I haven't paid attention to who was first, Kofi or
Yeah,
Randy.
so
Do you
I
know?
think my yeah, so
Were
I
you
think my
first?
question was
So go ahead,
been
Kofi.
answered. I I was going to ask, so who pays for these surgeries? I mean, and I think Chris just mentioned that I guess some insurance companies actually do.
Oh,
But
yeah.
I'm surprised that because the insurance companies usually base their willingness to pay for things on very sort of strict, we know this works or this does not work, and so we're not going to pay for it. So I'm surprised that given the sort of the dearth of efficacy of these surgeries, and that some insurance companies actually pay for them. And
Oh,
by the
I
way,
think a
Chris,
lot
and
of
by
them
the
are
way,
paying
Chris,
for
I'm
them.
also a Hokie, so
Oh, what's that? You're
I
also
said,
a
by the way, I'm
Hokie.
also a Hokie, so
Yay, go Hokies. Go Virginia Tech. Well, so this is beyond, but what's happening here? It's the same thing happening. A lot of my work is in, pro-life work, looking at the research in abortion, and it's the same thing. It doesn't matter what they put out these terrible studies, and then they put them up as gospel, and there's an ideology, I think it's satanic, and behind both of these, and um, yeah, it's horrendous.
I just wanted to add to your question, and maybe it'll help somebody else, Christina, about the insurance. It's ironic that I couldn't get a referral to get in, but when it was an ER visit twice, the insurance had to end up paying for it anyway.
Hmm.
And I just thought if you had given the referrals approval, I wouldn't have been in this situation. So I
Well,
don't know.
that's a whole nother problem in the medical system. There's a lot of problems in the medical system for sure.
I'm wondering though if you know if you're requiring insurance to pay, isn't that kind of an opportunity for the parent to step in if the parent hasn't been asked the question in the first place?
Absolutely,
But
yeah.
you have states where parents are refusing. This has happened where a parent refuses to transition their child and their child is being taken away from them. I think somebody put in this, I
Ah,
mean, it is getting out of control. This is not the world we thought we lived in 10 years ago.
wow.
And it's, again, as I read more about this, it's not, it's, and again, you should have somebody on to speak about all the ideology behind this because that's not my area, but it's just, the agenda is horrendous. And so what, like I mentioned, that's why I wanted to talk about the ideology. So it used to be called gender identity disorder. But they take away disorder because they want to normalize it. This has all been being normalized over many years. Um, it and they take away disorder, but they still include it in as a disorder in the book only because they can get insurance. And everybody's jumped on this bandwagon.
Randy,
Um, yeah.
Randy, go
Yeah,
ahead.
no, thanks. And Christina, this is an amazing talk and really informative and very, very interesting. So I had two questions. One is I've listened to it was an NPR or PBS report on kind of all the European medical society and how they've really pushed back. And I know you've um, spoken about that a little bit, but I think that's a really interesting question. Just sort of the break between the U.S. and Europe. And Europe is not usually shy about doing left-leaning social experiments, right? So that's
Right.
an interesting thing. The other question that I have is the is just the causes. Like I can imagine if you go back to the 1960s and you shared with a group of adults that in the 2020s a significant portion of young girls are going to think they're boys and young boys are going to think they're girls. I mean, people would just find that completely unfathomable, and yet here we
Yeah.
are. And so what sort of, and I know you mentioned social media is one thing, but what else I've heard and read about a little bit, and I don't know if it's if there's any meaningful relationship. But could there be environmental causes? Like I know that there are microplastics that are presumably in the air and in the water and impact are reported to impact reproduction. And like some have argued that maybe the clarity between male and female, even at the time of reproduction, is blurred a little bit by that environmental component. So anyway, just
Oh
if
boy.
there's if any of those are credible possible explanations.
I've not read anything that would connect that. I mean, I think obviously there's many environmental things that we don't know the causes, but this is a philosophical agenda. There is an intentional agenda to infiltrate our schools, to infiltrate our kids, to I mean, it's it's a whole critical race theory. Um, you know, Carl Truman's book, um, what's his book? Rise and Fall of the Human Self, or Strange New World, or but it's not. This is not happening by accident. I think it's intentional. Um,
Hmm.
you know, pushing this philosophy on kids. Now, there are kids that 50 years ago had gender dysphoria, but again, they were very rare. There are, something's different now, and but yeah, it's beyond just medicine overlooking things. It's a whole ideology. All right, we have some more questions. I don't
John
know.
Cano, do you want to be next?
Yes, thank you, Doctor, for your very enlightening presentation. I kind of wish you ended it on a more upbeat note. But anyway, I have three quick questions. And excuse me if I mispronounce the names. What is De La Chapelle syndrome? What is Sawyer syndrome? And what is the percentage of people that have these syndromes?
So you're a Swyer syndrome. These are very rare syndromes. So you're asking me about what people call intersex conditions. That I believe, is that what you're asking about? Because that's
Yes,
something.
yes.
So a lot of times people will say, "Well, see, look at these intersex. There are conditions where someone may have ambiguous genitalia at birth. It's very rare. I mean, again, I've delivered thousands of babies. I saw this once in Africa. It's not. So, and this is being conflated with transgenderism.
Mhm.
So they are completely different. So when in embryologic development, there's two paths. There's the male path, which is started, with if someone has a Y chromosome, then they go down the male path and form um, male organs, and if they don't have the Y, they go down the female path. Sometimes something goes wrong on one of those paths and things don't quite form normally, but there's not a third path. And this is, I just noticed Ryan Matthews was on the team with me that did the transgender evaluation, and I realized he just put out a white paper on this because he did the this whole intersex discussion. So that's on RTB's website, I believe for free. That a thorough evaluation. I haven't read it yet, but intersex people. So most people with one of these, we call them disorders of sexual development. Most of these people are clearly, there's no question about their sex. For example, Turner syndrome. This is a female with only one X chromosome, not two. Well, yeah, there's some things abnormal with their reproduction, but they're clearly female. No one ever questions that. And so, yes, the more severe conditions are very rare, but they're not a third sex. There were something's gone wrong, not
Mhm.
and they shouldn't be confused with transgender. So I don't know if that answers your question. Those, but on those, that's a situation with those syndromes.
No, I appreciate it. Bi Biology was a long time ago for me, so you kind of explained, but genetics was one branch that really interested me. So,
Mhm.
but yeah, the bottom line is it's very rare.
This is a big
Well, it's
distortion
also
of
not
genetics.
transgenderism. It's not the same
Yeah,
thing.
Yeah.
that's true.
So,
That's true. It's a
somebody,
biological.
right, exactly.
Okay,
Okay, thank you,
Hilmar,
doctor.
I think Hilmar is next.
Hello. Two questions. The first one's very simple. Can anyone access the white paper that you contributed to and where?
Yes, reasons.org. I don't know if Kirby
Well,
or somebody could put that in the
yeah,
chat.
as a matter of fact, one of our neighbors who was responding to me after I sent out my invitation pointed out that she had to identify herself in order to get the paper. So I sent her a courtesy copy. I'll be happy if any of you want a courtesy copy of that white paper, I'll be happy to forward it to you. So you don't need to go to Reasons to Believe and expose your identity to, unless you want to.
Although if you're willing to do that, I'm sure that that would be, good for them to see that people are interested or
True.
whatever. But
Yeah.
but yeah, if you go to reasons.org, I think it'll pop right up the gender identity white papers, and they are free.
Great.
So that was the easy question.
That's the easy question.
Okay.
The other part is I actually have two acquaintances in connection to my previous church, and I still have dealings with both of these people. One is a lady who has a teenager who is transitioning. I believe she's still in the social transitioning part of it. And the other one is a man my age, let's say, that has a son who is a transvestite. That I'm not sure if he's like, he might be transsexual too. But in these two people support each other as parents of people with gender dysphoria, and I'm trying to give them, sort of help them,
So
like
are these kids, are they under 18 or over 18?
So in one case, the lady, her daughter is 14, 15, I think. And in the other case, it's the father is his son is an adult already.
Yeah, I mean, these are can you imagine? This is very difficult for a parent. And there's not easy answers. I mean, it's a long road. I would encourage any parent to do anything they can to not send their kid down this path, but to educate themselves. There's a lot of good resources. I would recommend Miriam Grossman's book. Yeah, there's a lot of good information. I can get a list together or whatever, but parents need to align themselves with the right organizations and help and get their kid in with. Sometimes it involves pulling their kid out of their school or moving or getting them out of their environment, but it is a very hard situation,
and the problem, I may not have expressed myself properly, but both these acquaintances of mine are these parents have accepted their children's decisions and are supporting them. And it says, so and I'm their friends, or to some extent, and I am trying to educate them and maintain the friendship so I can continue to be an influence. So,
well, I think it's interesting you say that, because I give this talk is very medically and clinically whatever, but when you're down to a person, it's a different situation. I have a friend who's transgender. Not a good friend, but I'm involved in Toastmasters. I joined about a year and a half ago, and somebody in my group is transitioned, and they don't know anything about my views on this, because right now I'm just trying to build that relationship and find some common ground. And this is an adult, so and they're already down that path. Like, it's not like I have no thoughts I'm going to rescue somebody, but as a Christian, we just want to love people and walk alongside them. And so with this person, I'm really just trying to we both have cats and we have these funny cat stories. And so, and this person's married to somebody, it gets very complicated but it's been good for me to see, these are real people and I can give you the data and what's right and wrong, but not that we ever want to affirm somebody in this path and agree with this path, but we have to walk carefully and love them and speak truth in love.
Yeah,
Yeah.
thanks.
It's not easy.
And just a comment. I'm in Canada, so here you don't need
Yeah.
insurance. You can get all this stuff for free.
Mhm.
Wow.
Well, Harry, I think you're next.
Hi, thank you. By the way, I'm a retired epidemiologist, so I appreciate your view on the lack of good studies. But what I wanted to mention is about 10 to 15 years ago, I had a coworker who transitioned. He
Yeah.
used to be part of a group that I went out to lunch with on Fridays. He's 6'6", and when he transitioned from male to female, he was allowed to play on a girls' basketball team in college.
Yeah.
But
Yep.
the question is, there was an obvious trigger with him. He coached girls' basketball for many, many years. And in our lunch conversations, he would just constantly talk about it. And then privately talking with him, it was the attraction to girls, coaching them, that led him to a decision to have a transition.
Hmm.
And so,
Wait, this person was born male
born male,
and you knew him as a male?
I knew him as a male. He came back as female, and we overlapped after that for about a year before I changed jobs. So after she came back to work. Um, our relationship changed. No longer was this guys group to go out to lunch
Right.
with, and so it changed the relationship. But I'm just wondering, for his case, it was obviously being attracted to girls that was the part of what he talked about of why he wanted to become a female. And I'm just thinking about the reasons why young people, I mean, you mentioned a lot of things like social media and the culture at school and things like that. But are there other triggers
Yeah.
besides those?
Yeah. So what you're saying, I mean, most males are attracted to females. So that doesn't make sense to me, and I've never heard that as a reason. So as an epidemiologist, it's usually multifactorial. There's usually a lot of things going on. So, for example, the abuse issue, there's stories where young girls say they're cornered in a bathroom, they're abused by a male, and then there's stories where these girls feel that, well, if I'm not safe as a girl, so if I become a boy, I'll be safe, then no one will hurt me. There are people that don't feel accepted, and so it's cool to be transgender. They're a privileged group, and so actually what people that detransition will describe is that they had so much support as a transgender person, and then when they detransition, they lose that support. So it's people seeking support. There, there's certainly I don't, people are put on labels because they have certain preferences, stereotypes, although I don't know that that's a factor, but there are a lot of things playing into this. And again, we have to remember in transgender kids, there's a higher incidence of autism, higher incidence of mental health. So, you know, it's concerning to me that anything would be done until these other issues are addressed.
Mhm.
So the kid who's depressed, and a lot of times these kids think if they transition, then their world will be fixed, and then they find out it's not.
Mhm.
Hmm.
But Yeah, I think there's a lot of of reasons for that.
Yeah. Thank you, because as an epidemiologist, you mentioned like multifactorial. I understand.
Right. Yes.
Yes.
Yes, of course you do.
Yeah, thank you.
Wes or Shelley?
Oh, okay, yes, I have a comment and then possibly a question. It's just disturbing and my heart breaks for these young children that are being subjected to surgeries. As a young child, I wanted to be a boy because boys had the best toys. I hated playing with dolls. I
Mhm.
loved sports, and I just thought why couldn't I have been born a boy?
Yeah.
And that was going on for a while, but then puberty hit. Thank God I wasn't born in this time period. Puberty
Right.
hit, and I realized, oh, I don't want to be a boy. I like boys.
Hmm.
And so I just wonder if these young children that haven't really hit puberty, they don't have the capacity. So what is going on with the parents that they don't allow that normal process to happen? Could that be part of the problem?
You're saying why are the parents allowing this?
Yes.
Yeah. Well, first of all, I um understand what you're saying. Like I look back on this stuff, I'm like, man, if I was growing up now, I might, you're 12, you're 11, you feel insecure, you don't feel pretty, or you don't feel this, and then you're like, well, I guess maybe I'm a boy. I mean, that's what these kids are being told. Well, I think a lot of it comes down to parents are being fed lies, and they're being told that this is the answer, and you know, it's like a lot of things. We, what is the name of our organization? Let the evidence speak. We need to speak truth, and get the information out there in whatever way because it's certainly harming our kids.
Yeah. How do you get the information out there?
Well, I think like anything, we all have our place. All can't do it all. Somebody put in the chat to go to your school board meetings. I have a friend who is on the forefront of fighting the battle about books in schools and I mean the books that are being put into elementary schools. It's pornography. It's terrible stuff, and so I think we all have a place. Ask God where you to work on. I mean, it's overwhelming. It was overwhelming to study this stuff because
It is.
it's like many of the battles that we face. You know, I think God has a different work uh, for each of us to do. But I would encourage everybody to get involved in their own
Thank
arena.
you. Yeah. Thanks so much for this. It was great.
Yeah.
Dr. Belinda Calabia,
Hey, hi.
your
So I've been
question, please.
looking at this statement about finally treatment for pediatric gender dysphoria that the U.S. Department of Health and Human Services put out just,
Yes.
it said May 1st. So I know that you had said you hadn't read the whole thing,
Right.
but I'm just curious, the statement, my question will be like, what can a physician do with this information? Or this recommendation that they state here, or is it like just to help them, like in case they don't agree, that they can just go ahead and not go forward with these different steps for transitioning, in the sense that it said the evidence for benefit of pediatric medical transition is very uncertain, while the evidence for harm is less uncertain. I'm just like, what does that mean?
Hmm.
And then when medical interventions pose unnecessary, disproportionate risks of harm, then the healthcare provider should refuse to offer them, even when they are preferred, requested, or demanded by patients. What is your take on, what how helpful is this going to be? I mean, like in the UK and in Europe, they basically said the data doesn't support this, and so therefore we're not going to support this anymore. We're not going to go forward with this. But I'm just wondering, what does this kind of statement look like in the US and how it might change
Well,
healthcare in yeah, going forward.
If I understand your question correctly, I mean, there are a lot of things. I mean, I think you're talking about how it's going to change the politics. And I think there have been changes, but is that your question?
I think I wonder if the politic or not necessarily. I just wonder whether or not what can physicians do with this information then at this point, because they're the ones who are treating.
Are you a physician?
I am, but I'm not a practicing
Okay.
physician. I'm just
So
curious, yeah,
here,
because I got the sense that some are being kind of forced ideologically to
well, they
do,
are.
yeah.
Exactly. It's the same thing with abortion. So it's the same thing with many things. If you're not on board with this certain ideology, you know, let me just explain. I'll give you an analogy with abortion. When I trained, 30 years ago, if you didn't do abortions, well, that was okay. We don't agree with you, but that's okay. We can agree to disagree. And now it's like if you don't do abortions, you're considered a bad doctor. But it's a very few. I think it's a very powerful few amount of people saying this, and then everybody thinks it. So people, you know, are afraid to work in a place where they might have a different view, or so more people need to stand up. A lot of it is just having courage. And if you know physicians, who are dealing with the gender dysphoria thing, I would encourage them to get involved with ACP, American College of Pediatricians. This is a great website, biologicalintegrity.com, that ACP is running with lots of information.
Mm-hmm.
But a physician who's in a place where they lose their job, if they don't go along with it, they need to get aligned with like-minded people, get aligned with groups that are telling the truth, and have people on their team fighting with them. Because unfortunately the ideology has taken over, and it's tough.
Yeah.
Sabina, or is it Kirk?
Hi.
Sabina.
So I'm thinking of someone, hey Ken. I'm thinking of someone in another organization who is a Christian and is for gender affirming care and has sort of an open mic, as it were, able to promote these views. And I have not approached this person to talk. It's a woman, but I have not approached her to talk about this because she has a mic, as it were. But I just think what wound does she have in her life? Someone dear to her who has gone through this and is choosing this, and now she's studying and going in this direction, saying, "Oh no, this is a good thing." So I guess it's more of a how can this be happening? And yet it is of purported Christian, saying this is what you need to do.
And you've got Christian friends whose kids have transitioned, and the parents, well, at least one.
Well, I have a friend who's not a Christian and is not much relating with me, whose son, whom I babysat as an infant, he was a boy, wants to be a girl. And I also have some friends where
So your other one.
I'm not sure if the other girl has transitioned to be a boy, but most likely I would be shocked. I would be incredibly grateful if she didn't, Anyway, so but just this situation of, we need to be alongside hurting people and sinning people and love and speak God's grace and be there alongside. One of the things I say to Kirk a lot is, Jesus was invited to the parties of the quote unquote worst sinners these days, and they wanted him there. And certainly he was not approving stuff. But I don't know. I mean, how do you How do you challenge some of this in ways that, is loving and it's like, no, the emperor, I'm sorry. There are no clothes.
So you bring up a couple issues or there's a couple facets to this because there's a lot, and this is outside of kind of what we're talking about here, but there's a lot going on in the Christian world where we see, I mean, people compromising in a way we never saw. It used to be that the people who challenged our beliefs were atheists. Now the people that challenge our beliefs are people who claim to be evangelical Christians and are denying the inerrancy of the Bible and are changing what the Bible says to read like they want it to read. And so, I don't know how close your friend is and what your relationship is. You know, I think it's not just putting information I mean, you may want to study about progressive Christianity and what's going on. I don't know if that's where your friend has gone. Like Elisa Childers has a good book on progressive Christianity, but that's a whole, um, because some Christians think, well, we have to be nice to these people, so we have to agree with them. And that's not loving.
Right.
To agree with someone when it's doing harm. There's another white paper on the website, which is on the biblical view of this whole issue by Ken Keithley, and that might be helpful because we have to come along as side people and love them, but that doesn't mean we affirm what they're doing. But unfortunately, there is a subset of people claiming to be Christians. I don't know their heart, obviously, but saying, the only loving thing is to let people transition and be who they are. Well, that's not truth. That's not what's good for people.
Yeah. William, why don't you go ahead?
Hey, how's it going? Can you guys hear me?
Yes.
Yes.
Hey, just wanted to thank you guys for hosting this. Definitely a very, very informative session. I just wanted to know kind of the legality, especially being a medical professional. So if somebody say they had like a pre-existing condition that would get exacerbated or become maybe life-threatening if they did a reassignment surgery, do you as a medical professional like have to go through with the surgery if they request it? Them knowing that they already have pre-existing conditions.
So what's the situation where?
I don't know. I'm just saying like kind of like a hypothetical. I don't know what would be the legality for that.
So here's what's changed too. So as a physician, I've taken the Hippocratic oath not to harm my patients. So, and like, I'm just going to use, let's say, some really risky surgery, but the patient has cancer and they're going to die if you don't have it. Well, you might do that surgery because it's worth the risk, but you also wouldn't do that surgery without sitting down with your patient saying, "Hey, look, you, here's the pros. This might cure your cancer, but also you might die from the surgery." And you have to sit down with people and explain that. And so, um, now I lost your question because I don't think that the gender surgery is beneficial anyway,
Yeah.
but it is my duty as a physician not to do anything to a patient or not to recommend a treatment in which the benefits don't outweigh the risk. So
Yeah. I think yeah.
I give the example, like if a young girl comes to my office and she's 12 and she's like, I don't like having my menstrual periods. Can you take my uterus out?
Oof.
Okay, sure. Let me take your uterus out. No, I'm to protect her, and that's not my role. That's not appropriate. That wouldn't be good care. It's not to do just what somebody wants because they want it. I don't know if that's answering your question, though.
Like I think it's more along the lines of if they understand the risks and they still want to go through with it, and it could potentially worsen well, I mean, obviously it does worsen their health, but like exacerbate an existing condition that they already know they have. Um, are you legally bound to go through with that surgery, or are you not?
no, I'm not going to do a surgery just because a patient wants it and knows the risks. So that's
Mhm.
how the gender people, so the way what
Gotcha.
they call, so we call this informed consent, which is
Mhm.
discussing, here's the surgery, here's the intervention, here's your alternatives, here's the risks and the benefits, here's what you can expect, here's what might happen, and the patient agrees. Well, in gender affirming care, they use something called the informed consent model, which is
Mhm.
an informed consent. The informed consent model just means, oh, the patient agrees with it, and so they want to go through. So just because the patient understands the risks doesn't mean it's the right thing to do. So
Yeah, of
that
course.
alone is not sufficient to proceed with something. I still have an obligation to act for the benefit of my patient, not to harm them,
Mhm.
to do the right thing.
Phyllis, you're next.
I think this probably pertains a little bit to Kurt and his wife's question. I had a student, this is pre-pandemic time, and the student was in my class for probably 10, 15 years, because I taught wellness classes for well over 30 years now. And I don't know which role he took on as he and his partner. I don't know which role he took, but I never, and I guess part of it is standing your ground as your faith and what you truly believe. But I, I treated him the same as every student in my class. We would have one-on-ones, and he'd ask me one day, and I said, "It's not you that I can't agree with. It's
Right,
the actions that you're doing. I love you just like the rest of the students in this
right.
class, and I'm not going to treat you any different, but my faith calls me to this duty." And it's letting, and he would always say, "You act different. You don't, you're not like the rest of the people." And I kind of think sometimes that's, as Christians, what we should do, as the Bible teaches us to do: love, but still be different than what's in this world.
I think they make a really good point because um, we do have to love people. We don't have to agree with them, but we clearly need to treat them. They are made in the image of God, and they're struggling, and it, to barrage them, whatever, so yeah, I mean, you see the stories where people aren't treated well or whatever, and that's not, we're to love people. You're exactly right. And your student recognized it. They knew what you stood for, but they also knew that you treated them right. And I think that's a very significant witness, actually.
And I still
I
get
think.
texts from him. They had moved to Virginia. Now they're back in LA. And I always say, "I'm praying about your situation." And I got a text already saying, "Thank you.
Yeah.
It's good to, hear from you." But
Yeah.
I get texts from him constantly over the years, as, making an
Yeah.
impression. And I just pray that he, God will just, because I'm not the one to save anybody. I'm just
Right.
the one to give the message.
Yeah. I love what you're saying. That's great.
Yeah.
I do too, and I think that this is maybe a good time for us to. Yeah, well, now I see Marina has stuck up her hand. How can I say no to Marina?
Sure.
So, Marina, go ahead.
Thank you, Kirby. Hi, everyone. Thank you, Dr. Christina, for a really great presentation. That was
Yes.
very necessary in our day and age right now, and we really appreciate it. I was just going to ask you, I know you talked about the triggers of this gender dysphoria like right now, and I wanted to ask you just to compare it again with like the triggers of like a few decades ago, because I really feel that right now one of the main triggers is just the school system and these teachers
Sure.
that are trying to push this ideology down these students' throats. And I'm so frustrated when people with this ideology, when they say like, well, you have to let them be what they want to be, or else you're being, unloving and unkind and uncaring. But really, these children are not even thinking about these things, only most of the time only because the teachers are bringing it up and pushing it down their throat and
Right.
teaching them these things that are so inappropriate and unnecessary and so evil. So I just wanted to share a little bit about that again, about how the triggers are just completely different, I think, nowadays than decades ago, because decades ago this kind of stuff wasn't in schools generally. And then also I work with some other good Christian conservative patriots, and one of them was on now. She may have left, but where we go around to city councils and school boards and we talk about these things, and we urge the school boards like to get these really inappropriate books, pornographic, really disgusting, evil books out of the libraries of these schools, which is also triggering this. And it's just absolutely evil. And like you said, yeah, we all have to work together and stop this evil. And every single one of us Christians has a role to play, whatever it is. But yeah, it's something that the enemy is pushing so much, it, especially because the Lord created identity, male and female, and he hates that. He hates the Lord, and he hates us, the enemy. And so this is why this is so rampant right now in our culture at the end times. But yeah, I just wanted to say that. But thank you again, Dr.
Yeah, thank you. So your question again is
just the how right now the triggers are just completely different, it seems, than the triggers that were like decades ago for this kind of gender dysphoria, this kind of subject that we're talking about. And just to comment again on how decades ago the school system wasn't teaching this, and that's one of the reasons we can probably say why this wasn't such a problem as it is right now. But right now, because the school system, the teachers are teaching this is why it has come to this right now, what we see.
Yeah, it was very rare. We didn't see it. It wasn't seen in adolescence. This didn't occur in adolescence, and now we're seeing it in these. But yeah, you're right. And again, it's horrendous what's being promoted. This is not an accident. This is being promoted. The drag queen story hours, the books in schools, and I don't, it's there. This isn't just a few schools out there. This is every school in the country. I think a Christian parent has a very difficult decision on, I don't. I went to a public school growing up, and it was fine. And you had your whatever, there were challenges or whatever, but it's a whole different world. And that's why I think we're seeing a lot more Christians homeschooling, pulling their kids out of public school, because the ideology there is evil, and it is being pushed on these kids from, it's being taught in math, it's being taught in everything. And yeah, it's you make a very good point, so thank you. Yeah.
Thank you.
Well, I think we should take this opportunity to thank Chris for a wonderful talk. And would you be comfortable, Chris, with closing us in a word of prayer?
Sure. Yeah. And thanks, everyone. I appreciate your having me, but let me pray. Heavenly Father, thank you for this wonderful group of people and coming to a talk on a Friday night. And Lord, this is an overwhelming situation as we see these young people being harmed, and they're hurting, Lord. And some of us have friends who are going through this or whose kids are. We ask for wisdom in dealing with them and knowing and help us to love them well and come alongside them, never to affirm false things or affirm sin, but also to love them well and to walk alongside them. And we pray for a change in our country, a change in Canada, a change in other countries. Lord, we pray that you would come against the enemy, because ultimately this is not a political battle, but a spiritual one. And so we ask for your protection on these kids, Lord, especially that you would protect their dear souls, and you would, those who have suffered and had mutilation of their bodies and being sold a bill of goods, that you would restore them and bring them to you and make a change in their life. In Jesus' name, amen.
Amen. And thank you again so much, Chris.
Yeah, thank you for having me.
Really appreciate it.
Great. All right. Thanks, everyone. Good night.
Okay.
Thank you.
Thanks all.
Good
Mhm.
night.
We're
Good
gonna
night.
end today.